Welcome to another deep dive.
Yeah.
Today we're going to be talking about something that's really important for you as a general practitioner, and that is female sexual dysfunction. We have a ton of new research here,
Mm.
and some of the stats are really pretty shocking. Actually, about 40% of women in the U.S. experience some type of sexual concern,
Wow.
and for about 12% of women, it actually causes them serious distress.
Yeah, that's a lot of patients who could be walking into our offices.
Yeah, it is.
Ah,
And it's something that we need to be prepared to talk to our patients about.
absolutely. What's really interesting is that female sexual dysfunction, it's not just one thing, it's a whole range of issues that can
Right.
affect a woman's sexual experience, from desire and arousal to orgasm and even pain.
Oh, wow. So we're not just talking about like low libido.
Right. The term female sexual dysfunction encompasses a lot of different difficulties, and a lot of women experience issues in multiple areas,
Okay.
which makes diagnosis and treatment a little bit more complicated.
So it's not just a simple checklist.
No, not at all.
Got it.
And although the DSM-5 does have specific criteria for diagnosing these issues, it's important to remember that a patient's concerns are valid, even if they don't perfectly fit those criteria. The most important thing is to really listen to your patients and understand their individual experiences and be open to exploring all the different treatment options.
So it sounds like a holistic approach is really important here.
It really is. When a patient comes to you with concerns about their sexual function, a thorough evaluation is essential.
Okay.
And that means looking at the physical aspects, of course, but also really thinking about the psychological and emotional factors that might be at play.
Yeah, I can imagine relationship dynamics playing a huge role.
They absolutely do. The quality of a woman's relationship, how open the communication is with her partner, and the level of intimacy that they share can all have a really profound impact on her sexual well-being.
So it's more than just prescribing a pill. We're really trying to get to know the patient as a whole person.
Precisely. And part of this holistic approach is understanding the patient's goals and expectations for treatment. Open and honest conversations are so important here. You really need to address any anxieties that they might have and work together to set realistic and achievable goals.
I bet these conversations can be really sensitive.
All right.
So how can GPs best navigate that?
You're right, they do require sensitivity. The key is to create a safe space for your patient so that they feel comfortable opening up to you. Let them know that these concerns are really common and that you're there to help them. You can start by asking open-ended questions about their relationship, their stress levels, and their medical history.
Hi.
And then you can kind of guide the conversation towards specifics about their sexual concerns. For example, are they looking to kind of reignite the spark with their partner, improve their own sense of desire, or is it more about addressing physical discomfort during intimacy?
So like putting together a puzzle to understand the whole picture.
Yeah. Well,
What are some practical steps that GPs can take when a patient does bring up these concerns?
Well, first and foremost, validate their feelings. Let them know they're not alone. And then try to get a timeline of when these issues started. Was it gradual? Was it sudden? Did it happen at the same time as any life changes or new medications?
Right. Those are really good points.
Yeah.
So once we have a better understanding of their situation, what are some of the key areas that we should focus on?
One thing that might surprise you is how much your overall health and well-being can impact your sexual function.
Okay.
Things like stress reduction, exercise, sleep, and addressing substance use.
Right. So all the things that we're already counseling our patients on for general health.
Uh,
But it's interesting to see that connection to sexual health as well.
Exactly. And it's often overlooked. You'd be surprised how much even a small reduction in daily stress achieved through something like 10 minutes of mindfulness practice each day can positively impact a woman's libido.
Wow. So just those basic lifestyle changes can really make a difference.
Yeah.
What are the role of relationships?
Relationships are super important. Encourage open communication with their partner. Sometimes just having those difficult conversations can really be a turning point. Don't hesitate to suggest couples therapy or sex therapy. These can be incredibly valuable resources, especially if communication breakdowns or unresolved conflicts are contributing to the issues.
That makes sense. It sounds like addressing body image concerns is important too.
You're right. Negative body image can have a significant impact on a woman's desire and satisfaction.
Yeah.
So addressing those concerns, whether through counseling, body-positive resources, or support with weight management, that can be another piece of the puzzle.
This is all really helpful, especially for GPs who maybe didn't receive a lot of training in this area.
You're spot on. I remember early in my own career feeling really unprepared to address these issues with my patients. But as we've seen, sexual health is a crucial part of overall well-being, and GPs are often the first line of contact for patients who are struggling with these issues.
Okay, so we've talked about the holistic approach and the importance of lifestyle and relationship factors. Now let's get into some specifics. What are some of the most common sexual function issues that GPs might encounter?
The most common one, and perhaps the most complex, is sexual interest arousal disorder. You might be familiar with the term low libido, but the terminology has actually evolved.
Okay. Tell me more about how the understanding of this has changed.
Well, research has shown that desire and arousal are very connected.
Huh.
That's why the DSM-5 replaced the older term sexual desire disorder with sexual interest arousal disorder.
So it's acknowledging that these two experiences often go hand in hand.
Exactly. And when we look at managing this, it's important to remember that relationship factors often play a significant role. As relationships mature, the initial intensity of desire can naturally fade.
Okay.
And that's not necessarily a problem unless it causes distress within the relationship.
So it becomes an issue when it starts to affect the couple's dynamic.
Right, and that's where those interventions we discussed earlier, like couples therapy and communication exercises, can be really helpful. Encouraging couples to find ways to bring back novelty and excitement into their relationship. Whether it's through date nights, trying new activities together, or exploring different forms of intimacy can make a big difference.
That makes a lot of sense. Now, I know there are also medications available for low libido. What's the latest on that?
There are a few options, but it's not as simple as just prescribing a pill. We need to carefully consider each patient's individual circumstances and discuss the potential benefits and risks.
Okay. Let's start with testosterone. I've heard it can be helpful for women, but there seems to be a lot of debate surrounding its use.
There is. While testosterone does play a role in female sexual function, its use in women is more nuanced than it is in men.
Right, because men's testosterone levels are naturally much higher.
Exactly. Now, research has shown that testosterone therapy can be effective in improving sexual function in some postmenopausal women, specifically those experiencing low libido related to menopause.
So it's not a first-line treatment, but it might be an option for specific cases.
Right. But even then, it's crucial to approach testosterone therapy with caution. The long-term safety data on its use in women is still limited,
Okay.
and there are potential side effects to consider, like acne, unwanted hair growth, and changes in cholesterol levels.
And I imagine there are specific considerations for premenopausal women.
Yes, we generally avoid prescribing testosterone to premenopausal women. The research on its effectiveness in this population is mixed, and there's the added concern of potential risks to a developing fetus if pregnancy occurs.
So it's really about weighing the potential benefits against the risks
Yeah.
and having that open conversation with the patient.
Absolutely. Now, besides testosterone, there are other hormonal options to consider, especially for postmenopausal women experiencing symptoms like hot flashes and vaginal dryness. Hormone therapy with estrogen, with or without progestin, can be helpful in these cases.
So those are some of the hormonal approaches. What about non-hormonal medications?
Yeah.
Are there any that have shown promise for treating low libido?
There are a few. One is flibanserin. It's the first drug specifically approved by the FDA for female sexual dysfunction in premenopausal women. It's taken daily and has shown some benefits in increasing sexual desire.
Okay.
However, one thing you'll want to be particularly cautious about with flibanserin is the risk of severe adverse events like fainting when combined with alcohol.
Oh, wow.
We'll link to a detailed safety profile in the show notes.
So it's not a magic bullet, but an option to consider for certain patients with careful monitoring, of course. Are there other non-hormonal medications that are sometimes used?
Yes. Sometimes bupropion, which is actually an antidepressant, is used off-label for this purpose. It has shown some potential benefits for low libido, and because it's been around for a while, we have more long-term safety data on it compared to flibanserin.
That's interesting. So it's kind of a repurposed medication for this particular use.
That's right. And then there's bremelanotide, a newer medication that's administered as an injection at least 45 minutes before anticipated sexual activity. It's been FDA approved for treating low sexual desire in premenopausal women. Trials have shown it can increase sexual desire and satisfaction for some women.
So it's an on-demand option rather than a daily medication.
Exactly. But like any medication, it comes with potential side effects, the most common being nausea, flushing, and headache.
It sounds like there's a whole spectrum of approaches to managing sexual interest arousal disorder, each with its own set of considerations.
That's right. And remember, these medications are just one piece of the puzzle. A comprehensive approach that addresses lifestyle relationships and psychological factors is crucial for achieving positive outcomes for your patients.
This has been incredibly helpful in understanding the complexities of sexual interest arousal disorder. Before we move on, I want to touch on something that I'm sure many GPs encounter. Patients coming in asking about natural supplements or herbal remedies for boosting libido. Do any of those actually work?
It's understandable that patients would be drawn to those products, but it's important to counsel them on the lack of scientific evidence supporting the efficacy or safety of most herbal supplements for female sexual dysfunction.
So more hype than helpfulness.
In most cases, yes. These products often lack proper regulation and haven't undergone rigorous scientific testing. Take Avlamil, for example, which is marketed as a libido booster. While some of the herbs in it might have estrogenic effects, research suggests they could potentially stimulate the growth of estrogen-dependent tumors.
Wow, that's concerning. So not only might these products be ineffective, but they could also pose potential risks.
Exactly. Another one you might come across is Zestra, a botanical massage oil. While some small studies have hinted at potential benefits, the evidence is far from conclusive.
So the bottom line is to approach those products with a healthy dose of skepticism and advise patients to prioritize evidence-based treatments.
Precisely. Now, shifting gears a bit, let's talk about another common concern, orgasmic disorder.
Okay, what's the typical approach to managing that?
With orgasmic disorder, the primary focus is on education, psychosocial interventions, and the use of devices like vibrators.
Vibrators. How do those play a role?
They can be very effective in helping women achieve orgasm by increasing clitoral blood flow and enhancing sensation. It's about providing patients with practical tools and techniques.
So it's not always about addressing a deep-seated psychological issue. Sometimes it's about providing practical solutions.
Exactly. Of course, addressing any underlying psychological factors that might be contributing, like anxiety or relationship issues, is still important. But sometimes a simple tool like a vibrator can make a big difference.
That's really interesting. It highlights how important it is to keep an open mind and consider all angles.
Absolutely. And speaking of considering all angles, let's move on to another issue that can significantly impact a woman's sexual experience, sexual pain.
Okay, when a patient presents with pain during intercourse, where do we even begin?
The key is to identify the underlying cause and tailor the treatment accordingly. There's no one-size-fits-all solution here.
So what are some of the most common culprits?
Well, one that comes to mind, especially if the patient is postmenopausal, is genitourinary syndrome of menopause, or GSM.
Oh, yes, GSM.
Uh,
That's related to the hormonal changes after menopause, right?
Exactly. Those hormonal changes can lead to vaginal dryness and thinning, making intercourse quite painful.
So if a patient is describing pain during intercourse and she's postmenopausal, GSM is a likely culprit. A simple question about vaginal dryness can be your first clue. What are the treatment options for GSM?
We have a range of effective treatments for GSM, including over-the-counter lubricants and moisturizers. For more persistent symptoms, low-dose vaginal estrogen therapy can be incredibly helpful.
And those are generally well tolerated.
Yes, they are, especially the low-dose vaginal estrogen. It's applied directly to the vagina, so it has minimal systemic absorption, which reduces the risk of side effects.
That's good to know. Now, what if the pain isn't related to GSM? What other conditions should we be considering?
There are a few other possibilities. Vulvodynia, for example, is a condition that involves chronic vulvar pain, which can make intercourse very painful.
So it's not just about pain during intercourse. It's about pain in the vulvar area in general.
Right. And then there are skin conditions like lichen sclerosus, which can also cause pain. It's important to perform a thorough pelvic exam to look for signs of these conditions.
So don't jump to conclusions.
Yeah,
A comprehensive evaluation is key.
exactly. And keep in mind that managing sexual pain often requires a collaborative approach. Depending on the cause, you might need to involve other specialists like a dermatologist, a pain management specialist, or a pelvic floor physical therapist.
This has been incredibly helpful in understanding the nuances of sexual pain. It really highlights the importance of listening to our patients, asking the right questions, and knowing when to bring in other specialists.
You summed it up perfectly. We've covered a lot of ground today, but there's still so much more to explore.
That's right.
And with that, I think it's important to touch on a question that often comes up when discussing treatments for female sexual dysfunction.
Okay, what's...
The role of medications like PDE5 inhibitors. You're probably familiar with these as they're widely used for erectile dysfunction in men.
Yes, the little blue pill. But I've heard they're not as effective for women. So right.
That's right. While PDE5 inhibitors like sildenafil work really well for men by increasing blood flow to the penis, their effectiveness for women has been much less consistent.
Is that because the physiology of arousal is different in women?
It's definitely part of it. Blood flow is important for female arousal, but it's not the only factor.
So simply increasing blood flow to the genitals isn't necessarily the answer for women.
Exactly. However, there's one specific situation where PDE5 inhibitors have shown some promise for women.
I'm curious. Tell me more.
When sexual dysfunction is a side effect of certain antidepressants, specifically SSRIs, SSRIs are often prescribed for depression and anxiety, but they're notorious for causing sexual side effects.
That's right. I've had patients complain about that. So in those cases, a PDE5 inhibitor might help counteract those effects.
That's the idea. Studies have shown that sildenafil can improve arousal and orgasm in premenopausal women experiencing SSRI-induced sexual dysfunction.
Interesting. So it's not a cure-all, but a potential tool for a specific subset of patients.
Exactly. And it's important to note that the FDA has not approved PDE5 inhibitors for use in women, so this would be considered an off-label use.
Got it. So thorough discussion of the risks and benefits with the patient is essential.
Absolutely. Now, shifting gears a bit, I want to talk about something that's really crucial when it comes to managing female sexual dysfunction, debunking myths and managing expectations. There's a lot of misinformation out there, especially regarding herbal supplements.
It's funny you mentioned that. Just the other day, a patient came in asking about a supplement she saw advertised online as a miracle cure for low libido. I had to gently steer her towards evidence-based approaches.
It happens all the time. Patients are bombarded with these marketing claims, and it's our job to help them separate fact from fiction. While some patients might experience a placebo effect with these supplements, it's important to emphasize that their safety and efficacy are often unproven.
So what are some common myths or misconceptions you've encountered, and how do you address them with patients?
One of the biggest misconceptions is that low libido is always a sign of a serious medical problem. While it's important to rule out any underlying medical conditions, oftentimes low libido is simply a result of lifestyle factors, stress, or relationship dynamics.
So that initial reassurance can be really important. Let them know that it's not necessarily something to be alarmed about.
Exactly. Another myth I often hear is that all women should have a high sex drive all the time. This just isn't realistic. Women's sexual desire fluctuates naturally throughout their lives, influenced by things like hormones, stress, and even just their mood on a given day.
That's a really important point. There's no normal when it comes to libido. What about the idea that all women should be able to achieve orgasm through intercourse alone?
That's another big one. The reality is that many women need additional clitoral stimulation to reach orgasm, and that's perfectly normal.
So part of it is educating patients about their own bodies and what works for them.
Absolutely. And this ties into another myth, that using vibrators or other sex toys is somehow wrong or unnatural. These tools can be incredibly helpful in enhancing pleasure and achieving orgasm, and there's absolutely no shame in incorporating them into one's sex life.
So it's about normalizing those conversations and helping patients feel comfortable exploring different options.
Precisely. And speaking of exploring different options, I think it's important to address the topic of medications for female sexual dysfunction.
Yes, let's talk about that. In the last segment, we delved into some of the hormonal and non-hormonal medications that are sometimes used for low libido. Are there any other medications that are commonly used for other types of sexual dysfunction, like pain during intercourse?
For pain during intercourse, the medication approach depends largely on the underlying cause. As we talked about earlier, if it's related to GSM, then low-dose vaginal estrogen is often very effective. But if the pain is caused by something like vulvodynia, then medications like topical lidocaine or tricyclic antidepressants might be recommended for pain management.
And I mentioned those would be prescribed by a specialist, like a gynecologist or a baby management doctor.
In most cases, yes. These medications are not typically prescribed by a GP, but it's important for GPs to be aware of them and to know when to refer patients to a specialist for further evaluation and treatment.
So it's about having that awareness of the different options available and knowing when to bring in other members of the healthcare team.
Absolutely. And speaking of collaboration, I want to emphasize the importance of a multidisciplinary approach when it comes to managing female sexual dysfunction. This might involve working with mental health professionals, pelvic floor therapists, or even sex therapists, depending on the patient's individual needs.
It sounds like creating that network of support for the patient can be incredibly beneficial.
It really can. And remember, you as the GP play a crucial role in coordinating this care and ensuring the patient feels supported and heard throughout the process.
This has been a really insightful discussion on managing expectations and dispelling myths. I think it's especially valuable for GPs, who might be the first point of contact for patients struggling with these issues.
You're absolutely right. And, one of the most important things GPs can do is simply create that safe and non-judgmental space for patients to open up about their concerns.
I couldn't agree more. By being open and approachable, We can encourage patients to feel more comfortable discussing these sensitive topics and seeking the help they need.
Exactly. And that's what it's all about, empowering women to take control of their sexual health and live their lives to the fullest.
Well said. And with that, we'll wrap up part 2 of our deep dive into female sexual dysfunction. Stay tuned for part 3, where we'll delve into specific patient scenarios and discuss practical tips for navigating those sometimes challenging conversations. Okay, we're back for the last part of our deep dive on female sexual dysfunction, and we've covered a lot of ground so far. From understanding the different types, to exploring the treatments, debunking those common myths. Now let's kind of put it all together and talk about some specific patient scenarios.
Sounds great to me. I think that's where the real learning happens.
Yeah, absolutely. So let's say a 45-year-old woman walks into your office. She's generally healthy, but she mentions that she's been feeling kind of stressed lately and admits that her sex drive just isn't what it used to be. Where would you even start?
Well, that's definitely a scenario that a lot of GPs are going to see. And remember,
Yeah.
it all starts with creating that open and non-judgmental space that we talked about earlier. Let her know that these concerns are really common and that you're there to help.
So how do you gently guide the conversation?
Well, you could start by asking those open-ended questions about her relationship, her stress levels, and any relevant medical history.
Okay.
And then you can kind of delve into the specifics about her sexual concerns. Does she want to kind of reignite that spark with her partner? Is she looking to improve her own sense of desire? Or is it more about addressing any physical discomfort during intimacy? Really understanding her motivation is key to developing a tailored treatment plan.
It's like detective work, piecing together the different factors
Yeah, it is in a way.
that might be contributing to the issue.
Now, in this case, considering her age and that she mentions stress, it's important to consider the possibility of perimenopause.
Okay.
Hormonal fluctuations during this stage can really impact sexual function.
So would you recommend doing any hormone testing?
It's not always necessary, but it can be helpful to get a clearer picture of her hormonal status.
Okay.
If the testing shows that she is in perimenopause, you can talk about all the different options for managing those changes, like lifestyle modifications, hormone therapy, or other targeted interventions.
That makes sense. Now, what if her hormone levels are normal? What other avenues would you explore?
If hormones aren't the main issue, then it's time to look more closely at those lifestyle factors we talked about earlier. Is she getting enough sleep? How is her diet? Is she exercising regularly? All those things can have a big impact on stress levels, energy, and ultimately libido.
So those basic pillars of health really do make a difference.
They do. And don't forget about the power of stress management techniques.
Oh, right.
Things like mindfulness meditation or yoga can be real game changers for a lot of women experiencing low libido that's related to stress.
And then we can't forget about relationships.
Of course. Encouraging her to talk openly with her partner and suggesting couples therapy or even just giving her some resources on how to spice things up in their relationship can be really helpful.
It's about empowering her to address the issue from different angles.
Exactly. Now, let's say a 60-year-old woman comes in complaining of pain during intercourse. What are your first thoughts?
Well, given her age, I'd probably be thinking about genitourinary syndrome of menopause or GSM.
That's a great observation. GSM is really common in postmenopausal women, so it's definitely something to keep in mind. But remember, GSM isn't the only possibility.
What else should we be thinking about?
Well, other conditions like vulvodynia or even skin conditions like lichen sclerosis can also cause pain during intercourse. A thorough pelvic exam is really important to check for any signs of those conditions.
Okay, so we shouldn't jump to conclusions.
Nope. A comprehensive evaluation is key. If the exam suggests it is GSM, then we have a whole range of effective treatments, as we talked about earlier.
Right.
Vaginal lubricants and moisturizers are a good first step. And for more persistent symptoms, low-dose vaginal estrogen therapy can be incredibly effective.
And if the pain is related to vulvodynia or something else?
Well, then the treatment would have to be specific to that condition. Vulvodynia, for example, often requires a multidisciplinary approach involving pain management specialists, pelvic floor, physical therapists, and sometimes even mental health professionals.
Right. This shows how important it is to collaborate and know when to refer patients to other specialists.
It does. Managing female sexual dysfunction effectively often requires a team effort.
I think these scenarios are really helpful in understanding how to put all of this information into practice.
Yeah, I agree. It's one thing to learn the concepts, but it's another to actually apply them in those real-life situations.
Absolutely. This deep dive has been so valuable, and I'm sure our listeners are feeling much more equipped to address these issues with their patients.
I hope so. And remember, the most important thing is to approach these conversations with empathy, sensitivity, and a willingness to really listen and learn.
Couldn't agree more.
Yeah.
Just by being open and approachable, we can encourage our patients to feel comfortable discussing these sensitive topics and to get the help that they need.
Exactly. That's what it's all about, empowering women to take control of their sexual health and to live their lives to the fullest.
Well said. Thank you for joining us on this deep dive into female sexual dysfunction.
Mm.
We hope you found it insightful and helpful in your practice. Until next time, keep diving deep.